Interesting.
Hi, everyone.
Welcome, welcome.
Welcome.
Good
Thank you.
afternoon, good morning.
Thank you for joining us today. So we're just gonna wait a couple of minutes to get started, just to let people, log in. But while we're waiting, can you please share in the chat, your name, where you're located, and yeah, what's your work setting, your role? And if you want to share something fun about yourself, feel free to do so. So I see that we have people coming in.
Let us know. Hopefully the chat is
Yeah, the
working.
settings.
We've been trying to lock down our security a little bit. Thank you, Quinn, for letting us know
Yay,
that.
we have one vote.
Yeah, we've got 19 folks in the room
Cheering.
now.
Well,
Um, and y'all can use the chat function and also the Q&A.
Hi, Kristen. Thanks for joining us. Hi, Blaine. Ohio caseworker. Nice.
right.
So we're just gonna wait 2 more minutes
Hi,
and
Han.
we will get started. Oh, hi, I'm glad that you could join us. Hi, Sawyer. All right, so while we wait for folks to join us, let's do introductions. So today the topic is the how of tobacco harm reduction, and I am Gaby Zavala Aleman, pronouns they, she. I am a clinical social worker, a master's in biomedical sciences, and I am the project manager for the tobacco harm reduction education and engagement project here at National Harm Reduction Coalition. And I will let my coworkers and colleagues introduce themselves. Um, yeah, Harmony.
Yeah, hi everyone. Thanks for being here. Harmony Seberg, she, her pronouns. I'm based in New York City. I've been at NHRC for 4 years now as a national program coordinator. And yeah, I'll just be more like back end stuff, sharing resources as they come through. But if you have any questions, again, Q&A is open. And yeah, just excited for the conversation today. I'm going to pass it to Jesse.
Hello, good morning, good afternoon, everyone. My name is Jessie Fanini. My pronouns are they, them, and I am also based out of New York City. I am the NYC Capacity Building Coordinator with NHRC. It is a pleasure to be here with all of you. Let us know if you have any questions by using the Q&A function or just dropping things in the chat. And welcome to today's session.
Thank you. Appreciate y'all's being here. Welcome. I see that we have Kevin and Shay, and yeah, people have been just dropping in, and appreciate your introductions. And so let's just get started with the how of tobacco harm reduction. So, introductions for our org. So we create National Harm Reduction Coalition, create spaces for dialogue and action that help heal the harms caused by racialized drug policies. And yeah, we are celebrating our 30th anniversary. And the way that we achieve this is through policy and advocacy, national and regional conferences, trainings and technical assistance, overdose prevention, and we provide resources and publications. And so today, this training aims to explore the different modalities of tobacco harm reduction available on how providers can integrate them into their current programming. And so the learning objectives for today is to understand the relevance and impact of the core principles of tobacco harm reduction. So we will be going through the core principles to become familiar with multiple tobacco harm reduction strategies that are available to participants. And this will vary depending on regions and states, and we're gonna address that, and feel free to ask questions about that um, in the chat, or you can raise your hand and we will address it. And so another one of our objectives today is to learn the application of motivational interview strategies to engage in conversations about current tobacco use options, about harm reduction within syringe service programs, recovery community organizations, and outpatient treatment program services. We're also going to talk about, how to apply these strategies into street outreach settings as well. And finally, we're going to discuss how to incorporate assessment questions on tobacco use and harm reduction readiness knowledge. And so more specifically, we did introductions, we're doing agenda, and so we're going to get started with why tobacco harm reduction matters by defining it, and then its relevancy and overview of the tobacco harm reduction principles. Then we're going to move on to the modalities and strategies, product-based strategies, behavioral support, and then we're going to go deeper into motivational interviewing and assessment and readiness. And finally, we are going to do a closing. But before we get started with the content, we want to make a note of language. Because we know that the populations that we work with are highly stigmatized, words matter even more. And so they are a crucial role in establishing that rapport, that trust. And so by using person first language in our forms, our conversations, we are making a distinction between the individual and the behavior. And so, the approaching people in general, they don't have to be participants in this way, creates a more welcoming environment and humanizes the people that we work with. So some examples of the wording that can be stigmatizing: drug addict, prostitute, drug problem, clean or sober, crazy, infected with. It might be HIV or Hep C or any other array of communicable diseases. So we want to use person first language. So instead of addict, we want to say person who uses drugs, instead of prostitute, person who does sex work or sex worker. And yeah, instead of referring to people as like having a drug problem, it's better to refer to people as substance use, a person that uses substances. And yeah, if there is a disorder, then we add a diagnosis, then we add the disorder part. And we, instead of saying clean or sober, we refer as abstinence. Um, Crazy, even though people in in different movements have been reclaiming the word crazy. If you are a provider, you should refer to people as person living with mental health issues, etc. And finally, instead of infected with whichever disease or infection, a person living with, and fill in the blanks. And so it's important for us to note that people with lived experience or living experiences may self-identify with language that may not be appropriate to use as a provider. And so let's avoid doing that. And yeah, we always come come at this work from a humane perspective and a compassionate perspective. And if a person is using a stigmatizing word or just language in general to refer to themselves, we can approach it with curiosity to address that difference in language. So with said, I want to gauge your thoughts on what comes to mind when you hear tobacco harm reduction. And we are using a Menti. So you can scan the code and it'll take you to the page, which I will be um, projecting and fill in that code. Um, if Thank you, Jesse, for copying and pasting. I will switch to the word cloud that we are generating. Oh, all right. Um, so I see vaping, combustion alternatives, nicotine patch. Yes, thins. Yes, thank you. I will give y'all a moment. I see thing repeated. Survival. Yeah. So if you want to type in like a little bit of feedback on why you chose that word, I appreciate that sin is there twice. So it makes me think that people here know alternatives, and that's really cool. And also vaping, which has been very, let's say, not really embraced as an alternative. And we're going to talk about that a little bit more. Tobacco education, accurate information, yes. And you will be getting accurate information, alternatives, and I'm not going to pretend like I know everything about everything. So if there's something that we don't have the answer to in a direct way, we will address it. And so just drop it in the Q&A and we will definitely get back to you with an answer. All right. So thank you for your feedback. I see that we know what we will be talking about. And so thank you very much. And so why tobacco harm reduction matters. So before we say why it matters, let's talk about what it is. Um, so it applies the harm reduction principles to tobacco use, recognizing that while quitting like all tobacco and nicotine use is the safest option, people struggle to achieve or maintain abstinence. And, I have my vape right here. I'm not gonna pretend like I don't belong to this group of people that are embracing tobacco alternatives. And so tobacco harm reduction aims to minimize these health risks that are associated with combustible tobacco use by meeting people where they are without judgment, shame, or stigma. And so why does it matter? It really expands harm reduction beyond illicit drug use. And it's so we are bringing that compassion and evidence-based approach to tobacco use. It promotes informed choice, it reduces health disparities, and honors the dignity and autonomy of the people who use nicotine. And so it is particularly the need for THR. It is very acute among people with substance use disorders, participating in outpatient treatment programs, and for people that are in recovery. And so, some important facts to know is that smoking rates among people with substance use disorders are 2 to 4 times higher than the general population. And people that are in substance use treatment express often a desire to quit smoking, but there's additional challenges in actually doing it. And so people in recovery from other substances are at increased risk of relapse if they attempt to quit smoking without adequate support. So it's not that it can't be done, it's that we as providers need to be there, to give that appropriate support as the person requests it and what's in, their best expressed interest. And so tobacco related diseases are a leading cause of death among people who have overcome other substance use disorders. And so let's talk a little bit about the core principles of tobacco harm reduction, which align with the, harm reduction principles in a more broad sense. And so meet people where they are. So we need to be able to respect people who use nicotine just like we do, people who use other substances as the experts in their own lives. It requires us to build trust and provide safer options without judgment. Another one of the core principles is a focus on reducing harm, not demanding abstinence. And it requires us to recognize that switching from combustion to non-combustible nicotine products can significantly lower health risks, even if people continue to use nicotine. So that is something that right now, there's basically a push for bans on all tobacco products, and that includes safer nicotine alternatives. And so we're going to talk about those alternatives, but the message is that there's other factors to take in. And yes, one of the principles is to address inequities. And so it's the factors that might make switching to a safer alternative even harder to achieve are poverty, stress, stigma, and limited access to support. They all of that. Makes it harder for people to switch to safer alternatives or become abstinent if that's their goal. And so tobacco harm reduction seeks equitable access to those safer options. And yeah, how are people going to switch if they don't have accurate information? And so that's another one of the core principles is to empower through accurate information. And yeah, we as providers need to correct myths about nicotine, distinguish between the drug and the smoke that causes disease. And people just have the right to science-based, judgment-free education. And finally, Just we need to be able to support autonomy and choice in whichever setting we find ourselves. So, if the person wants to quit or they want to cut down or switch to a safer product, these are all valid goals. And so people deserve to be given options that fit their health, their culture, and their context. And now, let's see what we know about nicotine. I see people are engaging with the poll. There's still a few people that haven't answered. All right. I'm waiting for a couple of people. Oh, Sawyer, you're having difficulty with Menti. Um, yeah, we're doing the Zoom poll. Thank you, Jesse. Okay, so let's see what the results show. Oh, Sawyer, I'm gonna give you a minute to engage with the poll. All right. Harmony, am I showing the results?
Yeah, everyone should be seeing the results right now. Maybe if folks can see them, throw in like a heart or a thumbs up or something in the chat or the reaction. Oh, Han, I see your hand is up. Also, if anyone wants to be taken off mute to ask questions, with their voice,
Please.
yeah, just raise your hand and I can do. Oh, okay, cool. Some often a mistake, but just know that it's an option.
All right. So I see that let's go through each one of the statements. So nicotine causes cancer. So that was a half and half response. Interesting. Um, nicotine isn't considered a primary carcinogen in humans, so it's not the source of cancer per se. The major cancer risk from smoking cigarettes comes from the combustion products, not from the nicotine itself. And so, yeah, if anybody has any questions about that, we will be sharing the slides that have resources in them that we're going to go over at the end of the presentation. And so nicotine causes heart disease and strokes. And so most of you consider this a fact. And so even though nicotine contributes acutely, um, most, to cardiovascular, basically, to stress the cardiovascular system, most long-term damage from smoking is from other byproducts of combustion. Nicotine is harmless, and so everybody agrees that it is a myth. And so it is active, it's pharmacologically active in the system. it has effects, and it can be harmful in some contexts. And we're going to talk a little bit more about this shortly. And so finally, all nicotine products are equally risky. All right. So we've got 85% it's a myth. 15% is a fact, like voted that it's a fact. Um, I would like for somebody that to just give me some feedback on, why it's a fact. If anybody that voted that thinks it's a fact wants to type in the chat or raise their hands to let us know their perspective, that would be great. All right. So there's a continuum of risk in terms of nicotine products. And we're going to go over that continuum. But the short answer is that not all nicotine products are equally risky. So this is a myth. So a little bit about nicotine. And this is from the research that is available to us right now in terms of the language. So it is highly addictive. So it um, it is not fully benign, but the many other chemicals in tobacco, especially in the smoke, that's what makes the smoking of a cigarette harmful. Um, it is not the most dangerous component, and so nicotine-containing cessation medications like the gum and the patch and lozenges, are approved by the FDA as being safe and effective to help adults quit. And so nicotine stimulates systems in the brain that are important for thinking and memory. And so at University of Vanderbilt Mind Study, the patch is being used as an evidence-based therapy for smoking cessations. But researchers believe that it could be used to treat other conditions like memory loss, mental illness, and Parkinson's disease. And I will share with you in the chat the link really quick um, for you to be able to access the web the results. And that is a slide deck with the results explained. But basically, they're studying the potential benefits to test whether it could improve or alleviate symptoms of memory loss in people with mild and mild cognitive impairment, and possibly delay or prevent its progression to Alzheimer's disease. Um, Long story short, to give you the update on that, it has shown a short-term promise in alleviating the symptoms, but not in the long term. And so this study has opened up, a lot of given us a lot of information on how exactly nicotine works in the brain. And so these are some other ways that the research community is working, I guess, exploring in terms of potentials of nicotine for ADHD, depression, Parkinson's disease, sarcoma. And yeah, we were going to share some peer-reviewed articles that are open source that you could access on different information regarding nicotine and alternatives, etc. And so, like I mentioned, there is a continuum of risk with tobacco products. And so on the slide, we are looking at, at this continuum that is a public health framework that shows us that not all tobacco and nicotine products carry, the same level of harm. And so the biggest driver of harm is smoke, specifically the chemicals created by combustion, and which is burning. So the greatest risks are to the left are the combustible products. And so cigarettes, they sit at the far left because they're the most dangerous nicotine product. And so when tobacco is burned, it produces thousands of toxic chemicals and tar that can cause cancer, heart disease, lung disease, and other negative health impacts. And so, yeah, the messages, the nicotine is not what's providing the greatest risk. It is the smoke, the burning, to be exact, combustion. And so, biddies and cigars are next. They are used less frequently. However, they still produce large amounts of smoke. So that's why they are on the farther left of the risk scale. And so these are like hand rolled unfiltered cigarettes. They're very popular in India, and they are cheaper than cigarettes with filters. So that's something to have into consideration. And moving on, we've got water pipes. And so water pipes, we sometimes think that it's filtered because the smoke is passing through water, but the charcoal produces carbon monoxide and a lot of particles. And so also the context of the use is usually in lounges. It's a very social context, which means that the smoking sessions are longer, so there's more exposure. And moving on to the right, which is we've got chewing tobacco, which is non-combustible, which is why it's farther to the right, but it still contains the tobacco leaf. So it means that there are carcinogens present. It increases the risk of oral cancer and gum disease. So that's something to take into consideration as well. And we move on to, heat not burn products. They're heated tobacco products. And so they heat it up without fully burning it. Um, and because there's less combustion, there's a significant reduction in the amount of toxicants. Doesn't mean that there's no toxic chemicals, but there's a lot less. Um, and so they are lower risk than smoking, but higher than non-tobacco nicotine products. And now we move on to the lower risks, and that's where we find e-cigarettes, vapes. Um, they heat the liquid that contains nicotine, but doesn't burn tobacco. So again, they produce fewer toxic chemicals than cigarettes. They are not harmless, but the evidence is consistently showing that it is substantially less harmful than smoking. And the latest number I read, it's that is 95% safer than smoking, but don't misinterpret it as it's has fully safe. Because like I mentioned, the safest option is to just not do it, but we need to be real with the context of use, and that it's not going to go away. And so then we've got snus. I don't really know how to pronounce it. So if anybody knows, they can tell me. It's a moist tobacco product that's usually used in Sweden. It doesn't require burning. And the data shows very low rates of tobacco-related disease amongst the people that use it, but it still contains tobacco, and so there is some risk, but it is way lower than smoking. And finally, it's like nicotine without the tobacco. So those are the least risky options. So we've got nicotine pouches that only, um, they only have nicotine. There's no smoke, no tobacco specific carcinogens, and they fall on that lower risk and finally, nicotine replacement therapy, which could be patches, gums, lozenges, and yeah, they are FDA approved cessation tools, but they are controlled in pharmaceutical doses, and they're designed to reduce the withdrawal without like introducing the chemicals that are found in tobacco. Any questions so far? Thank you, Kevin. Snooze. All right, that's what I thought. Appreciate it. And so let's move on to combustible tobacco alternatives, which is basically what I've mentioned, but let's go a little bit into more detail. And I will take it like from the continuum of risk, from the heat not burn onto the right because they pose the least risk. And so we've got the heat not burn products, and so which are technically called heated tobacco products. And they use electronic heating elements to just heat sticks or plugs or capsules that contain processed tobacco leaf, making it into an aerosol instead of burning like regular cigarettes. Um, all right, so these are some pictures, and you can Google for some more. There's actually these products were introduced in the US, but there was a patent legal battle about it, and they were removed from the market. So yeah, it was being used and then it wasn't anymore. Um, and now we move on to the vapes, basically. They heat a nicotine containing liquid. It is substantially less harmful than smoking, and it is vapes I have found in my personal experience to satisfy the um the craving for the nicotine as well as for the breathing, that oral fixation that could be a reason to get started on cigarettes. And I am lucky enough to live in Puerto Rico where there are no flavor bans. And so, I have a strawberry watermelon one with me and I have a sweet tooth. So, it just it's been really helpful in reducing my smoking cigarettes. And these are disposable ones, but we have there's like refillable ones. And again, you can, yeah, just do a quick Google search for images, and you'll see a lot more branding and options. And so we've got this news, which I already mentioned in the continuum of risk, and yeah, it's mostly used in Sweden, and they are again lower risk because there is no combustion. And we've got the nicotine pouches. Um, I'm sorry, I am parched. One moment. Oh, I did not hold up. I think I'm not in the right slide. Well, it's got this misinformation, but nicotine pouches, like the ones that y'all mentioned in the word cloud through the Mentee, come in different various flavors and dosages, and they are a really good alternative to that nicotine craving. And we've got finally the nicotine replacement therapy. And so NRT come in patches, gums, lozenges, and there's toothpicks as well. And they are FDA approved. And they have, again, the lowest risk profile of all of the nuts. And so those are the product based alternatives that people have to smoking cigarettes, but we also need behavioral support. And so how does that look? Like what can we do? Stress and cue management. So it's helping participants identify situations, emotions, or routines that trigger smoking. And that could be stress or boredom or conflict, or social cues, substance use preparation. I have the habit, or it's part of my routine, or one of the cues is that if I get too stressed, and I will just pick up a cigarette without like thinking about the fact that I am doing that. So helping people identify like what is causing the stress, or managing that stress in other ways, other coping mechanisms, is really helpful. And so, like, just as an example, a participant might notice that they smoke every time they feel overwhelmed after talking to family. And one thing we could do as providers is to uplift the fact that that is a stress cue. And so we could we could aid people in coming up with their ideas of how they could manage that cue precisely. And we could offer lozenges if we have them available for that craving, teaching breathing techniques. But the takeaway is the stress will not go away, but we can shift that response. And so another type of behavioral support that is very important is peer support. So using community connection and shared lived experiences to support tobacco harm reduction goals. It is really important that participants get a sense of belonging, not only to their own culture, families, etc., but just in the society in general. So by having peers, we are normalizing harm reduction. We are reducing shame. We are reducing stigma around tobacco conversations, and people will just feel more comfortable talking about their stressors, their cues, and their options. And we're going to go a little bit deeper into that in a couple slides. And there's also habit substitution and routine awareness. And so it's recognizing habitual patterns that are tied to smoking. Like I every time that I have a meal, I will have a cigarette afterwards to help with digestion. Like, that's a habit that I identified, and I was able to change it, and not reach for that cigarette immediately. Just, do some breathing and just, kind of mindfully think about what it is that I want, and out of that habit. And so the suggestion is to replace smoking behavior with a less harmful option that still meets that need. Um, and so we're going to go deeper into the motivational interview for tobacco harm reduction. And so, but before we go into the explanation, I'm going to present a scenario, and you are going to think about ways to respond to the participant statement. And so I will read it. So this is the background for our scenario in a syringe service program, particularly. Maria is a 42-year-old Afro-Latina woman from the Bronx. She recently left an abusive relationship and is staying with her cousin while navigating unstable housing and intermittent fentanyl use. She regularly visits the SSP for syringes, a wound care, Narcan, and supportive connection. And we know that she wants to slowly cut back on fentanyl because she wants to be present for her teenage son, but the stress in her life, it feels overwhelming. Cigarettes give her a moment to decompress. And so, um, this is what she's saying in this scenario. And I just pasted um, the slide so you can read it. Mira, I know I'm smoking like a chimney lately, pero life's been crazy. Every time I try to chill, algo pasa. I can't be thinking about quitting cigarettes right now. I'm just trying to breathe. And so that's what you hear. Um, and these are the options of like which best aligns with tobacco harm reduction when supporting Maria. And a poll just popped up for you to vote. Thank you for participating. Appreciate it. All right, I have got, um, am I sharing the results? I'm sorry, I don't usually do
I
polls.
just shared them.
Oh, thank you so much. All right, so I've got that most of you chose option A. And who wants to explain why this is aligned with THR? Use the chat. You can raise your hand. What things are we taking into account when we are, just addressing? Yes. Um,
So option A, first does not shame the person who is using nicotine to ease some of the stresses in their life. And it also does offer support in the form of education while acknowledging their feelings on the situation and why they are engaging in use.
that is very aligned, and thank you. I really appreciate that. You're taking the THR core principles and taking them into like practice. So thank you. And so before we go into motivational interview per se, we need to talk about the trans theoretical model of change. And so this is a model for the treatment of substance use that was originally developed for tobacco cessation. And so the image that we're looking at, oh, and it was Francesca and Di Clemente in 1982 who published the model. And so we are looking at these stages, and basically it's pre-contemplation when, just people are not willing to consider the change, or they're just unaware of the need for change. It's like I that's pre-contemplation, so you're not, like, the word kind of hints at you're not even thinking about it. You don't see it as a problem. Thank you, Harmony, for sharing the PDF. And so then the next stage is contemplation. People are ambivalent. They're considering a change, and it's like a back and forth. And I that's between the pre-contemplation, contemplation, and preparation, which is like people are open and preparing for change. That's where the majority of people are. And so we tend to focus on the later steps in the stages in this particular model, um, which is, I already mentioned, preparation. Then we have got action. So we are developing the strategies to achieve a change, and that change is actually made. And maintenance is just being able to sustain that recent change. And just, if you're going to take anything away from this, is that while we're doing the motivational interviewing, we need to be conscious of where the people are. And by asking the questions, that's how we're going to be able to address it. And so, yeah, what is motivational interviewing? Um, I should have not put the slide, but it is an evidence-based approach that aligns with the model that I just showed you. Um, Thank you, Hen, for joining us. And yeah, good luck in your doctor's appointment. Going back to what it is, so it is aligned with the model of change that I just explained to you. And so just combining the motivational interview and this model of change, it's very useful for us to be able to understand and promote behavior change. Um, and like it says there, it doesn't have to be like a substance use disorder. It doesn't have to be tobacco. It could be you want to change your eating habits, or you have a harmful relationship with other things in your life. It could be coffee, it could be sugar. Doesn't have to be specifically tobacco, but it also gives us a framework to understand what works with this way of doing things. And so, um, motivational interviewing, it's a collaborative style that's going to strengthen the person's intrinsic motivation, and it's going to move them closer to change. It's a directive, it's person-centered, and they feel like that's the one of the things that's most important, that we are centering the person, and they are identifying and they are addressing their own needs by the type of questions that we're going to be asking. And so the core principles of motivational interviewing are PACE. Partnership is the first one. So collaborative, it's non-hierarchical relationship. Um, Another principle is acceptance, showing respect for the person's autonomy and worth. So we are going to be able to build a partnership if we show respect for the person's autonomy and worth. And this is all aligned to tobacco harm reduction principles, to like just more general harm reduction principles. And so the next principle is compassion. We are acting in the person's best interest, and we can feel that, we are humanizing them. And so that is very essential. And so the last principle is evocation. So we draw out the person's own ideas and motivation for change, because how are we gonna try to promote change in behavior, be it to, switch to a safer alternative, or to just not smoke anymore, no nicotine products or anything. How are we going to be able to promote change if we don't know what motivates the person? Um, so yeah, I want to ask a question. You can answer in the chat. What skills do you think you need to be able to, stick to those principles? And I'm gonna type it in the chat. So what skills do you think you need to stay true to these principles? Samuel says checking in with yourself on your own implicit biases. Yes, very important. Because we need to realize that even if we behave in a non-judgmental way, some thoughts will creep in, uh, and we need to address those. Brittany says empathy and curiosity. Yes. Um, or and so how do we um, actually show empathy and curiosity? Oh, hi, Robin. Being proactive for motivational interviewing, checking in with the participant. Thank you. So key communication skills for motivational interviewing. Open-ended questions. What are your thoughts about switching to vaping instead of do you want to switch to vaping? Because we want people to be able to talk about their own experiences. They are the experts in their own lives. And so another key communication skill is affirmations, acknowledging strengths and efforts. Like you've tried to quit before, it shows real determination. And like after we have um, given that affirmation or just validating the strengths and the efforts, we need to have the reflective listening skill. And so we can paraphrase or reflect on the deeper meaning of what the person is saying to show understanding. Like, you're tired of feeling controlled by your smoking. Sorry, one moment. All right, I'm back. Um, so yeah, I would say something along the lines of, so what I'm hearing is that you're tired of feeling controlled by your smoking. And then summarizing, which is pulling together the key points to show that, you've heard them and transition the conversation. And so an example. Um, So a staff member can ask the person, on a scale of 1 to 10, how important is it for you to switch to vaping right now? And then you follow up with what makes you a 5 and not a 1. And so that is making the person think about like, oh wait, I do care about this. And so it just enables reflection. And so instead, like the staff member, um, instead of just being like, oh, you know that vaping is way safer and da 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 da, and you have to switch right now, or saying you need to quit altogether, it's being compassionate, and saying it sounds like you're really struggling with the idea of switching, feeling stuck between the benefits and the difficulty. So we are putting those core principles like into action. And so the person discovers their own reasons to switch. And it builds confidence in their own ability um, to perform that change. And so that will elicit more commitment to making that change. And so let's tie together the model of change plus the motivational interviewing. So these two have been proven to be effective in tools in the management of people with substance use disorders, and it is our responsibility as helping professionals or just staff members of organizations that provide services in general. We need to develop the skills and knowledge, and practice of the evidence-based models to be able to, treat people with substance use disorders, and this is quoted from this research. We need to treat them with the highest standards of quality service, and so we all deserve the best service we can get, and that includes people who use drugs. And after this short 10-minute break, we will be going into more scenarios on how you would respond to a participant statement regarding THR. And so we will be back at 14 past the hour. I was speaking while muted. So if you're here, drop a reaction, just in the chat. Um, thank you. Loving the reactions. Appreciate it. All right. Um, Oops, sorry. All right, so let's go to a scenario. So we are in a recovery community organization. And if Harmony or Jesse could copy and paste the background on the statement for people to be able to read it. So Darius is a 29-year-old Black queer man active in the RCO for 2 years. He mentors newer members, facilitates groups, and takes pride in his recovery identity. He's been abstinent from cocaine and alcohol for over a year, and has previously stated that wants to train for a marathon as part of reclaiming his health, but his smoking affects his performance. And so he fears people in the recovery community will misinterpret a vape or nicotine replacement therapy as quote unquote slipping. And so this is what Darius is saying. I'm trying to get my life together, but the smoking thing, it's a one habit that won't let me go. And I'm not trying to have folks thinking I'm backsliding if they see me with a vape. You know how people talk. And so you as a provider and an RCO, um, which responds that supports motivational interviewing and tobacco harm reduction in a recovery community context. And the poll should be up. All right. Just a couple more people to participate. I will be back in a moment. I need to close my door. Okay. Um, so yes, we've got that. 94% of you answered with C. You've worked hard on your recovery and you want your choices to reflect that. Some people use vapes or a nicotine replacement therapy as tools that support their goals. We can explore options that fit your recovery values if you want. Um, and so we've got that 6% of you answered A, recovery spaces can feel judgmental sometimes. I'd get why you'd feel that pressure. And even though it's not the best option, or the option A, if you are not, you are at least acknowledging their hesitancy in terms of how they will be perceived. However, best choice aligned with motivational interviewing. Yeah, it would be the one that most of you chose. So thank you. It seems like you get it, and that's great. And so the conversation could go like you've built, just provider stating like you've built a strong identity regarding recovery and care about how your choices reflect that. And that is validating for the person. And yeah, and just, then you could say smoking is making your marathon training harder. And then you start exploring the options, but it needs to be a conversation. Because RCO participants may fear that stigma if they use less risky products or alternatives. And so, yeah, and this also is pulling from a focus group that we conducted a few months ago. And yeah, we will be talking more about that later. But yes, I'm not just these are not hypotheticals. These are like what actual people express. And so let's go to another scenario in an outpatient treatment program. And so Sujin is a 51-year-old Korean American woman, stable on methadone for 6 months. She previously worked long hours in nail salons and often feels overwhelmed by medical information in English. She attends counseling regularly and is rebuilding her relationship with her daughter. She hopes to reduce her methadone dose eventually, but wants to feel more emotionally steady first. Cigarettes help her manage anxiety, especially when she feels misunderstood. And so Sujin is saying, I've been smoking almost a pack and a half, maybe more. I'm thinking about switching to a vape, but I'm not sure if it's safe with methadone. The information is confusing and I don't want to make a mistake. And so, yeah, what response best reflects cultural humility and motivational interviewing when discussing vaping and methadone? And so, yeah, while you vote, you know, it this is important to address in this context because when people are in outpatient treatment, they fear medication conflicts, and so expressing cultural humility, which is not the same as competence. It means that you are recognizing that you are not an expert in anybody else's culture, and that you have an open mind to, listen, learn, and don't put the burden on the person to teach you about their culture. And so, right, taking that into account clear communication and having that, cultural humility really support engagement for tobacco harm reduction. And yeah, here are the results. And so it seems like, yeah, we're going to do one more scenario and then we are going to assessment and readiness. And yes, thank you all for voting. And so, last scenario for today. This is during street outreach. So the background is Andre is a 38-year-old Afro-Caribbean man with Jamaican roots who performs reggae and fusion music at local bars and events. Smoking is part of his show rhythm, stepping outside between sets, connecting with other musicians, and catching a breather. He visits the outreach van for supplies and support. He wants to cut back on heroin and hopes to reconnect with his sister someday, but doesn't feel stable enough for formal treatment. And so Andre is saying, when I'm doing my gigs, I step outside to smoke, get some air, talk with the other artists, reset my head. It's part of my rhythm. So please don't start with the quit smoking talk. Smoking's the one steady thing I've got. So how, which best which response best supports autonomy and tobacco harm reduction during street outreach? And this is really important, this scenario in particular, during doing street outreach, because it requires relational non-clinical engagement. And so smoking may serve social emotional and artistic functions as well. And so having gentle, autonomy centered tobacco harm reduction conversations are essential. And yeah, I see that only two people haven't voted. And all right, we are sharing results. And yes, by replying with your music and rhythm like matters to you and smoking fits into that flow. We are summarizing what the person has told you, and then offering. If you're curious about options, we are going to give them to you if you want. And that is one important way to respect autonomy. And so we now know how to have these conversations, starting points, but how do we assess, readiness, like knowledge and readiness? So, for SSP settings, the guidelines to developing tobacco use assessment questions, keep them brief and conversational, tied into existing um, harm reduction dialogue, and prioritize report and low burden. And so, in these settings, as some of you work in these settings, you know that interactions are brief and they are focused on the, more urgent needs like supplies, overdose prevention, or wound care. And so it should feel the tobacco use assessment like casual, normalized, and like not intrusive, not as if it would be, like an intake form in other contexts. Um, okay, so I have a question that just popped up and I want to just address it now. So what are the specific risks of vaping and where can I find evidence about this? Yeah, Jesse, you can answer if you want.
Apologies, I
All
clicked
right.
on the wrong thing, but I will be typing it in the chat.
Oh, okay. Thank you for that. And yeah, some simple questions like examples. Um, a lot of folks who come through here also smoke. What's your tobacco use like these days? Or when you're trying to get through the day, what role does smoking or vaping play for you? And have you ever thought about switching to something that's easier on your breathing? So notice that we are not like cops trying to find out, information. It's just kind of gauging, what the use looks like in an informal setting. And so what about recovery communities? So they're shaped by identity, community norms, recovery language. And so these conversations have to acknowledge the tension between being like in recovery and still using nicotine. And just a note on recovery, every person defines recovery like with their own standards. And, there are communities that define it in a specific way. So that is, the tension that is there. So the guidelines for developing these questions is acknowledging that recovery is part like of their identity. Like we need to acknowledge that, explore meanings and values, and reduce the stigma around nicotine discussions. So like, what does that look like specifically? Um, how does smoking or using nicotine fit into your recovery right now? Are there any changes you've thought about making with tobacco that feel like they support your recovery goals? And what would a healthier version of your nicotine use look like without needing to quit all at once? So, they these questions respect autonomy and recovery identity. They don't label nicotine use as recurrence or relapse or, have that negative connotation. And, it's an invitation for the person to define their own wellness goals, all in alignment with the theory of change that I presented and motivational interviewing strategies. And so let's move on to another setting. Does anybody have any questions so far? You can type them in the chat or raise your hand. All right. So let's move on to our next setting, which is outpatient treatment programs. And so the guidelines, more general, is like integrate tobacco into the clinical assessments, explore safety concerns and misinformation, and support individualized plans. So the difference, like one big difference in this setting in particular, is that usually participants have more time, and so interventions could be longer, and so that's something to take into account when we are developing the assessment questions. And so. Like example questions, like what questions do you have about using nicotine products while on methadone or buprenorphine? How does smoking affect your daily routines, like craving, stress, or energy levels? And if you ever wanted to try something less harsh than cigarettes, what would you want to know first? And I feel like these types of questions open up a conversation and don't assume. And so yeah, which should be one of the core principles of motivational interviewing in particular. And lastly, for street outreach settings, and so they usually like these conversations while doing outreach, like they can go in any way, you know? And so tobacco use often helps people regulate stress, socialize, or take a breather. And like when I was doing, outreach and case management, and I was out there, one way to measure the time that I had with each participant was like how long, I had enough time to have like one cigarette and I needed to be done because I had other people to like be provide the services to. And so that's like one aspect, like, and it is a shared common culture. And they asked me like, oh, do you have a cigarette? Like, can I have a cigarette? And that would also be a way to build rapport. And so I feel like getting to a point with participants that they are willing to address tobacco use in this context is, it can be hard, but it can be done. And so, general guidelines. So let's keep the questions grounded in the context. Acknowledge that smoking is a coping mechanism and social connection. and emphasizing non-judgmental curiosity. So, an example would be when you're out here moving through the day, how does smoking fit into your routine? What do cigarettes or nicotine do for you in those tougher moments? And if there were options that gave you that same break but hurt your lungs less, would you want to hear about them sometimes? And so it's always, 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 giving options and not judging. All right. And so let's look at, readiness because we have talked about developing these questions on tobacco use, but how do we assess readiness for change? Um, so first of all, let's define what a readiness assessment is. It is an evocation tool that is consistent with motivational interviewing, and it is a bridge between assessment and behavior change conversations. And so it's also a way to help participants articulate their own motivations. And so, like, what's the difference between motivational interviewing and a readiness assessment? So, motivational interviewing is the style, like, in what way you are going to, perform this readiness assessment. That is the technique. And so, with the style, using this technique, providers we can guide the conversations without putting pressure on the person, on the participant. And so, how to perform this readiness assessment? Ask the readiness question. So, on a scale from 0 to 10, how ready are you to make any small change to your tobacco use, even something tiny? And so, we use this to get a quick sense of where somebody is at, but it's not about the actual number. It's about the meaning of the number. And so, step two, reflect their answer, which is a motivational interviewing micro skill. So if they say 4, right? Like I said, the number isn't the focus. It's exploring why they chose that number. So, okay, so you're at a 4. That tells me you're not at 0. Something is making this feel at least possible for you. So again, we're validating while we are exploring like the meaning of that number. Next step. So, let's explore and what these are like the questions to ask to like be able to assess readiness. So why isn't a lower number? And so this brings out the change talk. So, what do they care about? And why is it not that they care less? So it's important for us to answer this ask this question because that's where we're going to identify you know the motivation that this person has, and we will be able to better address it. And so the next question that we need to ask when we're exploring the meaning of the number is what would help you move up by even 1 point? So why isn't it, why is it a 4 and not a 1 or a 0? Um, and, what would it take for you to go up? Simple, like what strategies? And so that way the person can, express what they thought about, what they have tried, or other strategies that we might not be thinking of actually. And so next, normalize, validate, and avoid pressure. So if they say 0, we are just going to say, 0 makes sense. You've got a lot going on. If that ever changes, just by a little bit, we can explore some options that don't add stress. And so, it's important that we don't push a conversation that the person doesn't want to have. And so an important aspect is that these readiness assessments, they aren't about getting someone to tell you that they're at a 7 when they're at a 4 or a 3. They're about understanding where they're at and supporting their autonomy. And so the next step would be, offer the options that are based on their readiness. And so these are just examples, like this is not set in stone. Um, and so, yeah, like these numbers are estimate and these are offerings from us to you on how to respond. But if, say, the person says, like, I'm at a 1 or I'm at a 2, I'm like not really like thinking about this too much. Well, we can offer info like if the person wants to hear it. At a range from a 4 to 6, we can, explore like small changes, like switching one cigarette for a vape or NRT. Um, it's exploring what feels possible for the person, and not what you wish the changes would look like. And so if the range is from like a 7 to 10, help them choose a strategy and let's move on to, implementing. And so that ties in to the model of change. And so I would say that if the person is answering like from a 1 to 3, well, they might be in pre-contemplation or contemplation. But if they're from a 4 to 6, I would say they might be in preparation, or just kind of exploring that ambivalence, but thinking about options. And from a 7 to 10, the person might be ready, like in that action, ready to take action and make a plan to make that change. Um, any questions that you might have, comments on this topic? I misplaced my water bottle. I will go get it really quick. Please use the chat like Jesse is saying. I will be right back.
I know we said this earlier as well, but yeah, if anyone wants to raise their hand and come off mute, we love to hear your voices. Sorry, the webinar experience is a little bit more closed off, but we love to get as much engagement as we can, still using the webinar format.
Thank you, Harmony. Yes. All right, so participant engagement, like what are some important things to take into account? So as harm reductionists, our recovery staff, treatment professionals, we need to stay informed about the debates that are going on around tobacco harm reduction, while we focus on the potential benefits for the people that we serve. And so, some helpful tips to support folks in exploring or, just considering tobacco harm reduction. Actively listen to understand with curiosity, openness, and without judgment. So this is It's hard because we have been taught, like at least my experience is that in many, spaces we are taught to just listen to reply and not to really understand. And so it's an active practice that we have to be aware of. How do I actively listen to understand? And so ask for clarifying like questions. If there is a word that you don't understand the meaning of because maybe it's like slang from a different scenario or context, then just ask for clarification. But make sure that you are, listening to understand and not to reply. Practice person-centered engagement and care. And this is a message that we will say in every training, webinar, etc. We need to center the person's lived experience, their expertise in their own lives, and tailor our interventions to that experience and to what they have stated they need. So, it's not enough to know, the struggles or the context. We need to know what they expect, what they want, what they need. Um, and so we need to be open to different perspectives because not everybody is going to align with our values, with our ways of seeing the world, but we do find commonalities, and that's where we need to, engage. And so, other tips: understand, acknowledge, and address the role that stigma plays in creating barriers to meaningful conversations. Um, and so maybe that stigma is not coming from you as a provider, even though we always have to check for our own biases and the snap judgments that we make. But stigma is bigger than just one person. It's societal. It could be interpersonal, like internalized, which is the struggle to like actually say out loud that you have internalized stigma. It could be interpersonal, it could be systemic. And so we need to acknowledge and address that is a barrier to having these conversations, and even a greater barrier to receiving appropriate care and information. And so another way to engage participants in various contexts is to demonstrate empathy, considering that any change, big or small, can be scary and hard. We need to see ourselves as collaborators and partners and remember to center the autonomy and voice of the participants in this process. And so that requires a lot of patience from us. I remember these tobacco harm reduction conversations are not really like a standard to have in my context in Puerto Rico. But I learned that even though I'm not talking about tobacco harm reduction, I was developing that patience for recognizing, when a person just like that readiness assessment, I could do that 1,000 times. And I remember a participant very dear to me that took 4 years to implement, like to take action into like doing what she considered that she needed to do to manage her stress, her anxiety, and to lower her substance use, including tobacco use. And so that's part of what's required of us as providers is to, be collaborators and also develop patience because we could write 1,000 care plans with specific dates of when stuff's going to happen. but that's not on us. It's not our responsibility and it's not our lives. And we just need to be able to, extend grace and be patient. And so finally, we need to do our research and work on educating ourselves on tobacco harm reduction. And so, yeah, it's very important that the conversations that we have are factual and not opinions. And it is, there's barriers to getting the facts because of, funding challenges, controversies in the field. And so definitely topic for another webinar training or just a space for conversation. But yeah, the main takeaway is let's educate ourselves so that we could help educate other people. And so now let's move on to our closing reflections. And the question that I am going to pose is why should you integrate tobacco harm reduction in your services? And you can go to the Menti or scan the QR code. I'm going to leave the QR up for a moment so that people can engage with it. And after this, I'm going to share some resources. All right. Why should you integrate THR in your services? Is I feel like is some are you replying or am I doing something wrong? If you can't engage with the mentee, just you can answer the question in the chat. It's an empathetic way of helping people engage in practices that present fewer health risks. Wow, it's a good synthesis. Um, oh, thank you for that, Allison. All right, noted. I will change the QR code next time. So, above all else, it reduces harm, provides more options for people and other funding source for the program, which always helps deliver more high quality services. And it supports autonomy because it helps meet people where they are. Any small wins matter. It might surprise people. They're able to look at cutting back in small ways. It acknowledges lived experience while helping support someone to make change on their terms. Many of the individuals we interact with may be at the pre-contemplative stage and may not know where to get information. Yes, um, I feel like that last one that I read is really it kind of popped out to me because we get all sorts of misinformation, and if we don't, like for example, my 22-year-old niece stated very confidently that vaping is worse than lighting up a cigarette, and she just took up a cigarette. And so I asked, like, who said that? Like, where's your source of information? And she's like, oh, no, just this is what my friends are saying. And so if we can, avoid people getting their information, we can't avoid people talking to their peers. But if they are in our services, it is our duty to provide the right info. And so Kevin is saying my niece recently did too about the comment. She saw a social media post about it. Thankfully, she didn't pick up a cigarette. Yes, Kevin. Yeah, so it's that's what the our project is about. Yes, Laura. Can you speak?
Yeah,
Oh,
I'm
perfect.
sorry. Can you hear me? I just added,
Yeah.
because it helps those of us who've been trying cessation for over 40 years of smoking, and I think it's very profound for those of us that no matter what we did, we couldn't attempt to quit. So I just want to say that it's very profound because the challenge for, heavy or medium smokers of decades is that we tried it all and it didn't work. And I'm still on my journey. I'm vaping, and I'm at this point this month smoking only 2 cigarettes with the goal of keeping one as long as I need to. But this has been transformative to me. And I used to do these trainings and say I was an eternal contemplator of quitting smoking, and now I could say I'm moving into action.
I am so proud of you. If Harmony, will Laura be able to like turn on the camera, introduce yourself with the settings? And if you want to, Laura.
I just
I
tried.
look terrible.
Okay, well then
I don't know if
I would
I don't
like
know if
you
it's
to
an
introduce
option.
yourself.
Yes, please introduce yourself.
Yeah, I'm Laura Guzman. I'm the executive director of National Harm Reduction Coalition, and I did trainings on motivational interviewing for decades for HRC, and always considering myself what I call an eternal contemplator of quitting smoking. So I'm very proud to be where I am. And I just read someone who says I was more proud of quitting smoking than crack, and I agree 100%. That is, I want to say nicotine, leaving tobacco smoking has been so hard for many of us.
Thank you, Laura, and thank you, Kristen, for sharing. Yes, it is. I am on my journey. Let's just say that. I am a dual user right now. And let me just share the resources really quick. And if you attended our previous training, some of these are on that other slide deck, but we've added some additional resources. So the Safer Nicotine Wiki, I just wanted to highlight that one. It's on tobacco harm reduction. It is on nicotine and safer alternatives, and yeah, it is volunteer led. It has a robust evidence-based information. It is a good starting point if you just want to, it's divided by topics, etc. And you can, just take it from there. And these are some other international resources. Laura, you wanted to mention something?
I just want to add that we put on the questions and answers the webinar that was just done by our street. That is a really phenomenal webinar, hearing from a lead of an SSP, hearing from a doctor, so hearing from four different women, hearing about policy, and when it's about an hour long, but it's so well done that it gives you kind of like the whole picture, including some of the questions that were in the Q&A. How much can we say about, vaping? What, how is it safer? What is that we cannot articulate about vaping, etc.
Thank you, Laura. And so we've got peer-reviewed research I've linked. These are all open source, so if you want to really dive deep into the data, we've got 2 pages of peer-reviewed research, and if you want more, you can email me or Harmony. I'm putting you on the spot. And we can definitely facilitate some more research from you. We've got some articles as well, and books. And you can scan the evaluation form. You should be getting, after you close the Zoom, a link to the evaluation form. But if not, you can scan this QR. Certificates will be given out. So please fill out the evaluation, and when we look at who attended, we will be completing those certificates. And thank you, Harmony, for sharing the training calendar. I'm going to share my email in the chat. And oh,
You'll find it in the training calendar that I shared as well, but we have the third training in this series coming March 11th, 2026, and that's supporting choice and autonomy, person-centered care, and tobacco harm reduction. So we hope to see everyone there.
and thank you for sharing space with us and attending this workshop. Hopefully, we will see you in March.
Thanks, everyone. Enjoy the rest of your day and weekend.
Happy Friday, y'all. Take care.